You guys ready for the most impressive Grand Rounds discussion you've ever had in your life? Stay tuned for next year, okay? No, but I'm excited. This is a fun time. I don't like public speaking. It's not one of my strengths, but I do like hearing you guys talk. And so that's the purpose of today, is to really get everybody interacting, because I learn more from you guys than you're gonna learn from me, I promise you. So with that, we're gonna almost jump into it. First, this has nothing to do with the conversation, but just last week, I was driving home and I pulled up behind this car and I immediately felt sorrow for the significant other of this vehicle. And my wallet actually went deeper in my pocket. It was the weirdest thing. Tis the season, I guess. So, all right, so why did I choose compassionate care? I actually had a recent experience that kind of woke me up to this idea of what compassionate care is. Just a few weeks ago, I was in clinic, and it was a Wednesday. It was my last patient of the day. And we have we call them patient care coordinators, medical assistant / scribe. And they basically do the intake and then come out and give us report on the patient. And so this is the report that I got, and I was tired. I don't know what it was. The week had gotten to me. I really was at my wit's end. And so I get this report. 29-year-old male with a history of a dirt bike accident 9 years ago, which caused a spinal cord injury and an emergent surgery to stabilize the spine. He complains of persistent pain from his ribs down to his lower extremities. He's on baclofen and opioids. He has done several injections but had to stop due to complications. So this was the report that I got. This is what I heard. 29-year-old motocross guy who injured his back and has had 9 years of chronic pain. He's taking pain medications. Injections are no longer an option. He's referred to us to manage his chronic pain. I went in, I was like, I don't want to do this. Like, I don't want to deal with this. And I don't know if you guys have ever been in that instance, but I was definitely there, right? And so fast forward, I walk into the appointment, and there's this gentleman, healthy looking guy, sitting in a wheelchair. And we had a very meaningful conversation. What turned out, he was just looking for anything to help him come off of the opioids, any other options to manage his pain, which was real. And I found out the mechanism of injury, and when it was described to me, I was in shock. He was on a dirt bike, went off of a jump. He kind of hit it at a corner and the bike slid out from under him. And somehow the bike got tumbling and ended up crashing right down on his chest. This was his image. I've never seen anything like it. He showed me this at the end of the appointment. I didn't have any of this imaging beforehand. And so it really resonated with me as I backing up a little bit. So, you know, one of the comments that he made, he was like, oh, I'm just so grateful, you know, that I have the use of my hands and my cognitive faculties. Like, you know, he was so grateful to be alive. And boy, I walked out of that and I was like, wow, that's perspective. You know, I went into this thinking one thing and came out, you know, feeling like he helped me more than I probably helped him. But we got him lined up with somebody that's going to do a spinal cord stimulator trial for him. We're hopeful that that's going to help in some way. But it really left me with this idea of how often do I feel like I walk into a patient room before I even get to know the patient, already predetermined on how the patient visit's going to be. And then that kind of just, you couple that with this trying to understand what compassionate care means in medicine. So kind of to open up the discussion, I really hope this is interactive. I just want to talk, so you don't want to hear me talk. So what does it mean to provide compassionate care? What does it mean to you guys? Have you guys thought about it?
So you mentioned, I think I have the same thing too, right? Like you hear the presentation or you hear the story and you start to categorize a little bit because a lot of the pathologies fall into particular categories and then you start to make assumptions about what you think is going on. And I think compassionate care is to really try to understand the individual story. one of them is unique and different and has their own twists and turns and tragedies and good things happen, and that can really allow you to treat that patient as an individual person.
I love that. And Brad, last week, where are you at, Brad? There you are. You talked about that. You left us with that. Every patient has a story, right? So I think it's very, very important. What else? What other things come to mind? Yeah.
I think the thing we have to remember, and we try to do that with our staff a lot, is that when people are coming to us, they're not actually having their best day. And if they're grumpy, we have to be a little bit more understanding the fact that they're probably in a good deal of pain. It's taken them a minute to get to where they are with us. And probably the same thing in your office. I mean, and in each of our offices, people are not having their best day. They're not, I always say, hey, good to see you. And they're like, I say, well, I'm happy you're here. I'm sure you're not happy you're here, but, and that's absolutely the truth. So I think it's just kind of bringing that perspective, but we're all guilty of that, drawing a picture of what's happening with the patient.
I was reminded when I walk into a patient room, almost every single time I'll ask, how are you doing today? And I think, why do I ask how you're doing? You're clearly probably not doing very well. And there's a few that give me the polite response, and others like, well, I'm not great, or I wouldn't be here. I'm like, well, perspective, yeah. So, love that. Steve?
I think compassionate care means that you may not understand everything. I had experienced this last week with a patient. It was on Friday, and we got off on the wrong foot. The visit did not go well, and I went away from that visit thinking, what could I have done different? She's stubborn, she's not listening. And I had experience over the weekend, and she kept coming back, her face kept coming back to me, and just got this thought, you need to apologize to her. You don't know what she's going through. So I went back in on Monday and visited her again, and I sat down and I said, I just want to tell you I'm sorry. I don't know what you're going through. I don't know what it is to have the things that you have. And we had a meaningful conversation for 40 minutes. But I think sometimes we have to step back as providers and understand that even though we have all of this experience, we don't know sometimes. And it's okay to not know and to be that humble to be able to say, I'm wrong. What do you need?
I love that. I love that. Please.
Yeah, kind of on those same lines. So after a decade of working with spinal cord stimulators and some chronic pain patients that are some of the most hopeless of this population that have just been through the ringer, those expectations that you talked about. Like I've watched some really good physicians just manage expectations, let the patient know a clear path to what's going to happen. Sometimes just offers a little glimmer of hope, and those patients just feel like, okay, this doctor's going to take care of me or help me figure something out, and that's what it is.
I love that. Yeah, thanks for sharing. So, kind of the literature would suggest that compassionate care consists of a deep sense of awareness of another person's suffering and the desire to alleviate that suffering. So with that, empathy is involved here, the ability to understand and share another person's feelings. But compassionate care goes a step further. This is like an actionable thing. You're doing everything in your power to try to help alleviate that suffering. That can be challenging. You think about the volume of patients that we see, and the repetition that we see too. Go ahead, jump in. Please. No, please.
Ask you, during your visit, when did you start feeling a sense of change?
That's a great question. It wasn't in the beginning. I was kind of filling out the scenario, this relationship we were establishing. I'm like, what is he looking for? I was waiting for that, and I need this or I need that. And I never got it, but it was probably about halfway through the conversation. And then at the end when he's like, do you want to see the picture? And I was like, yeah, absolutely. And then I was just blown away. It just like cemented in me like, man, I was wrong. Yeah, I was wrong. Jen.
I think the hardest part in healthcare is that we already have the desire to alleviate the suffering. And 90% of the time in my role, I already know how to fix their problem. But what they want is someone to listen to them. So, our office manager and I have found that if we are willing to listen to them, then by the time they get to the end of the conversation, sometimes they've solved their own problem, but they just want someone to hear what's going on.
Yeah, 100%. Do you have a comment?
I would just add to that, and that's what had me thinking. In Latin, the word companion means to break bread with somebody you share bread with, and so compassion, right, is to share your feelings or your passion to alleviate suffering and be there with the person. But the key component is calm. It's with. You have to be with them and not up in your head going, oh, this guy's chronic pain or he's got blah, 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 blah. And that with the patient part is really the heart of it.
Yeah, active listening, right? You're engaged. I love that. So, Dr. Ansha.
And I see this in my practice because my specialty is pain management, but just refraining till you actually hear the story from judgment, right? Because one of the things that comes from the initial part, the reason you walked into that room is pain medicine, right? This is not a patient I can help without knowing what the patient's intention is. But the conversation changed tone for you when you knew that they didn't want pain medication, they're looking for solution.
Yes.
And just not judging that somebody is wanting pain medication. If they want pain medication, that's okay too.
Yeah.
But I think they need to start trusting that you truly want to help them.
Yeah.
Whichever path, you lay out for them.
I love that. We gotta, I think Carolyn had talked about it before, our bias, right? We gotta leave that bias aside when we go into that patient interaction. So here's the question, is compassion innate or learned?
I think
Brad.
the thing that helps me the most in practice is all the suffering I've had myself, right? So you could say that's innate or maybe it's learned, throughout my life. Just the pain that I've been through just really connects me with patients. But I also think it's a practiced thing. You have to train yourself to rejuvenate appropriately, to be able to walk into a new conversation and have ultimate compassion and care for the next patient. Because you could have one difficult patient that just drains you, but you have to make a choice to reset before you go into that next conversation.
100% true. I love that. Yes, Kate.
We see this a lot in the hospital setting where we'll get feedback from patients and families saying, everybody was very nice. They were nice. But there was no connection. There's no compassion. So I think some people just innately, maybe life story, maybe just how they were raised, that connection and that compassion is a lot easier. And then there's this whole other group of people that either come in early on to practice and struggle with it, or sometimes kind of later, with burnout and all of that. So we work a lot about that really, it starts with connection. Because if you can truly connect with someone, and whether that's because you share a story, you saw an image, whatever it is that makes it real to you, maybe it's a patient that you say, oh, this reminds me of my mom, or whoever. When that connection can happen, then a lot of times we can lead to compassion. So I actually think it's both.
100%. I would agree. It's both. Please.
I'm going to say it's a little bit of both, but we've all had clinical mentors in our life as we were coming up through school and residency and things like that. And imagine if you had a mentor who was absent compassion. You might have thought that's the way you're supposed to treat patients. But we all think back to that one mentor we had who really connected in the room, and we said to ourselves, I think I want to be like this person. So to that end, each of us has a responsibility for those people that we mentor to teach them this skill so that they see that compassion is what's supposed to happen in interaction with a patient. So think about that piece as you're rushing through your day, especially if there's someone watching you. Realize you're raising the next generation of non-compassionate clinicians.
I love that. I actually have not thought about that, but we have pre-med, pre-medical. They're wanting to go into medicine. Students that are scribes, and they're in the room with us the entire time, watching our interactions with our patients, and they're picking out the good and the bad, and hopefully we are leaving a good impression, and they're taking away a lot of good from what we do. But it's a good reminder. So I love that. I love that. And then going back to your comment, working as a bedside nurse, I can attest, like, that early connection is so important. It makes the difference in a 12-hour shift. You've got to make a connection with the patient and earn their trust early on. So I'm going to try to make sure I stay on course here. Do we have another comment? Quiz time. Here we go. Who's in the top 3? Now, this study is old. It's outdated. But I just want you, it's still about the same. So this is specialty within in the physician realm. Okay? So who's top 3? Who are the top 3?
Psychiatry.
Psychiatry is number 1, yes.
Yeah, pediatrics.
Pediatrics, nailed it. Anything else?
Oncology.
It's up there.
Geriatrics.
It's up there.
Family medicine.
We'll just,
Palliative.
Pete.
Internal medicine.
who's in the bottom?
Orthopedics.
How far down the list are they?
Actually, there's been studies that show this. Yeah, orthopedists know this.
I love that you're here, Dr. Anderson. I'm so grateful you're here, so I don't get...
Bone broke, we fixed. That's kind of hard to...
Ortho.
But I think that's, generalized. Hey, Dr. Roncha, this study is outdated, okay? So.
And then came drugs.
Yes. This is the list. This is from 2002, so again, it's very outdated.
They
But,
wanted to study it again.
well, Japan did. So Japan did, and this is what they found. So this was more recent. Still OBGYN, psychiatry, pathology, general medicine. This surgery doesn't apply because in Japanese medicine, general surgery is much more encompassed than just surgery. So, and maybe it is here too. I don't know. But and then we're still winning though. Where is it? Neurological surgery, orthopedic surgery. So that's a win for me. I'm going to try to get through all of this and not... Okay. What are some common complaints regarding provider-patient interactions? What do we hear?
My doctor doesn't listen to me.
Doesn't listen. What else?
Short visit.
Short visit. Not enough time. Distracted. Any others?
Not present.
Not present. Not listening.
I have a daughter who was like, okay, forget it on this doctor because he didn't remember what her diagnosis was.
The patient feels like they don't understand.
They don't understand. You guys nailed them all, I think. So this is what I mean, and not that I know everything. These are just the common complaints. I never hear these, but I've heard them out.
Heard of, but never.
Yeah. I felt rushed during my appointment. I didn't feel like the provider listened to me. I left the appointment confused and with a lot of questions. I didn't feel like my concerns were prioritized or taken seriously. I felt like just another number. That's a big one. We don't want our patients to feel like just another number. And if they are, that's a problem. Now, onesies and twosies, we're going to have those hard interactions where a patient walks away and they're going to be upset. But we've got to do our best to try to make sure each patient feels individualized. You guys know what this is? Non-neurosurgeons in the room.
Yeah, it's a mass in the brain.
Mass in the brain.
Looks like it shouldn't be there.
Shouldn't be there. Aggressive tumor. Poor survival rates. I think it's 15 to 18 months. That's like the top end. So easy to have, easier, and maybe not everyone, to have compassionate care. To give this individual who may have a family, is young, a lot of life supposed to be left ahead of them that's cut short. Easy. So here's something different to think about. So this is another patient that I had, 52-year-old female with a past medical history of alcohol and nicotine use, BMI of 41.6, requires supplemental oxygen, prior back surgery, and is on methadone. Complains of severe neck, low back, and coccyx pain with nonspecific radiating leg symptoms. Has had pain for at least 7 years. What do you hear? Tough patient, right? Tough patient. Here's the scan. So she does have some pathology at 045. I mean, there's a degenerative disc. However, her presentation of symptoms just really didn't convince us that surgery was going to be helpful here. So we had a conversation with the patient and explained that we just didn't feel like surgery was the most appropriate approach here. And her response was, "It's because I'm on methadone. That's why you won't treat me." And I watched, because I was, Dr. Edwards was in the room at that point talking to the patient, and I'm the one that had brought up that the patient is on methadone. Dr. Edwards didn't even mention anything like that. I brought it up just to make sure we were all on the same page, just giving an appropriate history. And she immediately went to that. And I watched Dr. Edwards operate, and it was really interesting. We don't always get the perspective of sitting in a room and watching another provider interact with a patient, because that could have gone one of two ways. He could have became very defensive and like, basically, I'm done, wash my hands, okay, if you want to go somewhere else, But he stayed in the visit, he remained calm. He didn't allow that back and forth to go. He just, look, we're trying to help you, and I'm just trying to explain that based on the pathology in your back, I don't feel like surgery is going to help you. I do have, however, another answer. Going back to, we love stimulators. We have a lot of confidence in them. Maybe we could try a spinal cord stimulator. You have chronic pain. It's throughout your body. You're on methadone. He had a conversation about, opioids and how they affect our pain receptors and what that does to us. So at the end of the conversation, she actually left super happy. And that conversation could have went very differently in my mind. So just important things to be thinking about. Here's another one, 24-year-old female, works as a nurse with the neck and back pain, so I'm sympathetic, registered nurse. I've worked on the floor, I know what that feels like. Long shifts, standing on your feet, aggravated by twisting and walking. She's healthy and fit. Pain is so bad it leaves her in tears after a 12-hour shift. Pain present for several years, and she's tried physical therapy and other conservative treatments. Nothing has really helped, and it's progressively getting worse. Here's her scan. I immediately wanted to tell her, your lower back looks super healthy. Like, I really don't see a lot there. And I think I even maybe said that in some context, and she just, tears in her eyes. Like, not of gratitude or happiness, of sadness, of like, what? Why am I in so much pain? And so we as providers can definitely stop here and say, well, your back looks healthy, you don't need surgery. Sorry. And I kind of had to, this was a more challenging situation. I had to backtrack a little bit and find a way, and eventually I sent him to chiropractic. Said, I think they can fix you, so we're good. So why does compassion, for the sake of time, why does compassion matter in medicine? Research shows that compliance and adherence rates go up significantly, improves patient outcomes, and lowers excessive healthcare utilization. I hope that we all buy into this, that you can actually go out and research it. It's proven statistics out there. Compassionate care really matters. And what prevents us from giving and maintaining compassionate care in our practice? We talked a little bit about this. Compassionomics, this book here. I don't know, has anyone read this book, heard of this book? Interesting book. I encourage, if you get a chance, read it. 50 in the book, they talk about 56% of providers say they lack enough time to treat patients with compassion. So what is the solution? Well, they suggest the 40-second rule in it. Has anyone heard of the 40-second rule?
Well, in orthopedics, we're lucky if we get to 8 seconds. I think that's the direction you're going to go.
Well, yeah, and I think that this idea of how much time does it take to show compassion? It can be as simple as acknowledging the patient's feelings, acknowledging them as a person and saying, you know, I may not understand what you're going through, or I don't understand what you're going through, but I want to help in any way I can. Let's work together and figure out how we can help one another. I mean, that doesn't take a ton of time. And maybe you break it up into multiple visits. Dr. Edwards has always said, hey, don't be afraid to say, hey, this is a complicated case. Why don't we have you come back, you know, and take that extra time. So there's ways we can create time for our patients, for sure. You were going to say something?
I was just going to say, yeah. I was thinking the 8-second rule because studies have been done on orthopedist interactions with patients, and it takes about 8 seconds. The orthopedist is willing to listen for about 8 seconds, and then begins to steer the conversation
so
in the direction that he thinks is out.
The book talked about that in a general sense. 22 seconds it took for the provider to interrupt the patient as they were.
Yeah, orthopedics in 8 seconds.
So there you go. Yeah.
We deliver clinical care in teams, and so I think there might be a limitation on one provider, but a team can deliver compassionate care. It doesn't necessarily need to be a provider either. Jen, for example, is on the phone with patients I know almost every day, multiple times a day, just talking to them because they have concerns and questions, and that's compassionate.
Mm-hmm.
In our clinic, the PCCs can show compassion, as can the advanced practitioner team who have intentionally longer visits. And then I think it's good even for the busiest or the busy clinicians to just take a moment when you can. Last week, for example, between Saturday and Friday, 32 cases, and was on call. There was a point during the week when there were over 25 patients in the hospital that I was supposed to round on, and then my messages in clinic had piled up to about 40, all of whom needed a look to see. And so I was wrapping up messages last night, and I looked at one and I thought, you know what, I'm going to call that guy. And he had a tumor in his sacrum that had been removed, and it saved his life. He was left in all this pain, and somebody had done a spinal cord stimulator trial, and it gave him 99% improvement. So he just needed a stimulator from it, which is sort of no big deal, right? But I just thought I'd call him, and it was just such a pleasurable interaction, and he had just been hoping against hope that he could get this done as soon as possible, which might be possible, might not, I don't know. But
Yeah.
That can really help all of us to just seek out that connection, even amid a busy schedule. It didn't take more than 5 minutes to talk to him. That keeps us going too.
I love that. Spoken from a neurosurgeon, so we all got to be able to live up to that expectation for sure. So I think one last thing, I just want a couple of things and then we'll be done, but self-care I think is so important. I think we will have empathy fatigue if we don't take care of ourselves. But in that same vein, as we serve others, we're actually feeding ourselves. So that's something to remember. And I know you guys, I learned so much from watching you guys interact with patients or getting feedback from the patients that are in my office that have seen you. And that energizes me because I know we as a community have the best interests of the patient in mind, for the patient in mind. So, Henry David Thoreau said, could a greater miracle take place than if we could look through each other's eyes for an instant? And that's what I'd leave you with. So any last minute comments, anything? Thanks for coming today. Appreciate you.